Yeah, Hyeon Hospital is
Yeah, okay.
first. Okay,
Samsung
Dr. Kwon.
Hospital, Samsung Medical Center.
Yeah.
Welcome back. So, Dr. Finkelstein, you are with me all day.
Yes, I'm
Thank
following
you for your service. Okay,
by the
I
way, the last case,
Yeah.
we didn't see the final
Oh,
with the
really?
stent.
Yeah.
Was it okay?
Actually,
Was
I
it-
showed it in the coronary theater before the TAVI procedure. I
okay.
did the crush stenting, crush technique.
Yeah.
I used the two-stent technique, and the final result was good. Actually, the left main.
I know, I saw that.
Oh, yeah.
I mean, the last TAVI procedure,
TAVI procedure.
yeah, you had a coronary problem, and then you were supposed to put a stent there.
Actually, I thought we finished procedure during the live session. The FFL was before.
Yeah.
FFL
Was positive.
0.77, afterwards 0.72. So we stented. You are curious about the result of
No,
stenting.
we didn't see after the stenting.
Yes,
That's why I'm
Yeah,
asking.
it was good.
Okay,
Okay.
Believe me.
I told you, I'm following you. All right.
Okay, so I'd like to introduce today's team. So at the right side is the Dr. Kim Lam Chui from Hong Kong. He's the president of the Hong Kong Public Hospital Society of Cardiology, and also vice president of intervention cardiology in Hong Kong. So, and Dr. Song in the Samsung Medical Center. So, Dr. Song, can you introduce the case?
Okay, let me introduce the today's case. This is a 64-year-old male. He suffered from resting pain for 1 month. After that, the exertional chest pain, CCS class 3, and shortness of breath occurred. Nearly 1 month ago, he received percutaneous coronary intervention for right coronary artery CTO lesion in other hospital, but it failed. Echocardiography showed the normal systolic function without regional wall motion abnormality. His coronary risk factors were hypertension, hyperlipidemia, and smoking. Actually, he received PCI for proximal LAD region and mid RCA region with Texas stent nearly 11 years ago. Next slide, please. It showed the non-specific STT change in inferior lead without pathologic QA. Next slide. 1 month ago, the coronary angiography showed there's no significant stenosis on LAD, but retrograde 3 collateral was seen, and focal stenosis at PDA. Next. Actually, you can see here the totally occluded proximal RCA lesion, and the JCTO score was 3. Next. Okay, 1 month ago, they tried to open the proximal RCA CTO region, but they failed to open the region. Next. After that, the stress asylum scan was performed and showed that partially reversible large perfusion defect in inferior wall. Next. Okay.
So, patient is quite symptomatic. Now it's 1.5 months after first he felt resting chest pain. Is now CCS3 exertional chest pain. So I thought it was thrombotic ISL. So actually, this is not chronic. 1.5 months, not chronic total occlusion. So subacute total occlusion, subchronic, maybe. So I thought it is a quite good case for thrombosis suction or something like that. And the failed CTO, do iotronic dissection, and so issues here. How to avoid the subintimal space made in failed PCR, how to deal with large burden of thrombus, how to avoid the embolism in the proximal RCA. So, but you thought that this lesion is not so thrombotic, and
Right,
maybe
right.
the embolization, thrombus, residual thrombosis is not an issue.
Right.
You thought that?
I'm not sure how the panel thinks. We have some discussion among the three of us. And I think that they may start off with some thrombotic occlusion, but the thrombus load, at least currently, seems not to be high. And in any case, I think it's more than a month after the previous presentation. If anything, if we can pass the wire, personally, I don't think we have to deal with the thrombus very much. And in any case, the thrombus will be organized. So I'm not sure what is the opinion.
Actually, in this angiography in other hospital 1 month ago, there's the dye staining there. So actually, that was made by the tip injection in the pseudolumen, the subintimal injection of the contrast dye that then made the staining. So there is some track there. The 전전 슬라이드 left angio 좀 보여주세요. 전 하나 더.
하나 더 전이요.
더.
Previous.
Previous.
하나 더 할게요. Previous one.
Actually, they didn't wait enough until the filling of the stent. So, stent, inside of stent, you can see the RCA stent. There is no filling of dye contrast. So I thought total occlusion.
In the last few millimeter, there is, in the last few millimeter.
So I thought there would be some thrombus inside of it. The stent is large, RCA is large. So I worried about the thrombus.
Right.
But to make it clear, so today's angiography. So
Today angio.
엔지오 스크린 올려주세요. 엔지오를 메인 스크린으로. Okay, this is today's angio. So fortunately, the subintimal dissection was healed after just 2 weeks. No, 1 month.
1 month.
So, and next. Yeah, osteal, total occlusion. Next. So we did the left angio for a long time. Next. Next. Okay. Fortunately and disappointingly, stent inside was patent. I expected that the stent filled with a thrombus, but actually it is not. So next. Next. So actually, stent is not occluded. The lesion proximal to the stent was totally occluded 1.5 months ago. So now, please help me how to deal with it.
So any suggestions from the panelists?
Dr.
So,
Won, do you have
Yeah.
a CT scan?
No, not
No.
CT scan, Dr. Chung. He was recruited just a few days before the live demonstration.
Dr. Gwon, I'm Byung Kim. Could you show me again the RCA angiogram?
RC angio. John.
In your first patent,
Okay.
attempt PCI, the wire was into the stent or not? Wire was passing into the stent?
Outside the stent.
Outside the stent.
Actually, the problem was that in this view, in the LA view, wire was inside the stent, but in area view, actually wire was outside the stent, and they injected the contrast dye at that position, so it made a dissection outside the stent.
Dr. Gwon, by the clinical history, what do you think of the age of the occlusion?
Yeah, 1.5
at the
months.
time? Yeah,
1.5 months.
not that you can see
Not
that
chronic, not so chronic.
not the chronic.
Yeah.
Are you sure?
1.5. By the history.
Yeah.
if we trust that the previous presentation is the onset time of
Right.
occlusion.
That's why I was worried about the thrombus burden in this patient, but actually there was not.
So from the patient history and also on angiogram, even though we don't have some CT scan, so definitely some severe calcification was not noted. So I think anyways this case is antegrade CT of
antegrade
PCI.
approach,
It
yeah.
will be the first. So we can see some very promising the epicardial collateral channel. However,
Yeah,
so everybody
right.
knows
Yeah,
this
yeah.
kind of a good collateral channel always,
Right.
if we use this one, is sometimes a very severe
yeah.
ischemia
Yeah.
can occur. So I think anyways
So,
this case is
right.
the
Epicardial
antegrade. Yeah.
from LED to RC is well developed. So integrated approach is failed. We can easily change your integrated approach. So actually, in this case, I was looking at the crossbows. So actually, crossbows is quite good tool to follow the track inside of a stent. I thought it was the ISL total occlusion. Maybe they didn't find a way, but the crossbows can find the right way. So anyway, I like to use it today. So actually, next angio. Next, final, next. Actually, Gojon. So actually, maybe you may be interested in that. I usually use the XB guided catheter for RC CTO. And this is 7 French. 7 French is not always safe, but I use a 6 French. But even this 7 French XB 3.0 catheter was safely cannulated to RC ostium. So the wire inside was 0.035 wire hard tip that can control easily. So next. So this is the UV3 wire on the crossbows. Can you camera here?
여기 좀 비춰주세요.
여기 좋았어. So already crossbows inside. Inside the crossbows we have a UV3 wire. Okay. So next. Actually the direction of the wire is very important. So maybe I can be successful without the support of use of a crossbows, but I really like to use crossbows in this case. Otherwise, it's nothing to discuss. Okay. So actually, this is a demonstration. So I'm not sure crossbows is working here. So total occlusion from the RCA to the upper edge of the stent. So I removed wire was test always inside, a little bit directing the upper side. Anyway, a little bit.
Dr. Kwon?
Guiding backup is quite important. So I rotate it and make a better alignment.
Dr. Kwon?
Yep.
So actually, I could understand the use of the crossbows in this
right,
case.
yeah.
However,
Yeah.
this is not a stent ISR, and also even though in
Yeah.
case of the ISR case, anyway, the first initial supporting device is a usual supporting device would be better.
Yeah. Please forgive me that I really like to use crossbows. Crossbows is developed for CTO, and it will help find the way very easily. So I rotate it and a little bit push. So guiding support is very important. So I prefer the XB test. There was, yeah. Okay. XB support to a proximal RCA. I'm not sure it will work or not.
Dr. Gwon,
Yeah.
very rapid, quick rotation is very important.
Yeah,
Yeah.
I'm rotating as fast as possible. Yeah, going this way. Okay,
So check
RCA.
another one, yeah.
RCA. There was some advancement. How high is the RPM do you need? For the 3,000?
Yes.
Okay, check that without. It's going outside, right?
Right.
going outside.
So
The
this
same
is one
track.
of the previous track.
Yeah, it's
This is
following the previous track.
Right.
Okay, it's not working, right? It's
Right.
following the, if there is a previous track, the crossbows is not working.
So this
Anyway.
view is the RIO cranial view. Is just the RIO view is better to see the alignment of the stand location.
Yeah, array cranial,
Cranial is better.
for the proximal RC. This is array cranial. Do you want just the simple RAO?
Yes, please.
Yeah, RAO. Yeah, I can control the alignment. XB 3.0 is quite. Do you think I need to go further? It's going outside,
So maybe you can direct the wire to another track.
right?
Right.
Yeah. Okay, I give up here. Okay, so leave the wire. I gave up so quickly. So wire inside, the extension 좀 주세요.
Extension.
Removing the crossbars, we need the extension wire. Or trapping balloon. Of course.
Doctor, do you have any comments?
통과가 안 됐으니까 그냥.
Do you think the better way to use crossbars here?
That is crossbows. That's all.
Okay. 연결 좀.
So maybe this case is RCA itself is very big. Vessel size is more than 5 millimeter, I guess. We don't have any information on the CT findings, but actually the proximal RCA, including the stent side, is vessel itself is very big. So last first attempt, the wire is going to the lux subintima, but I think it is not lux subintima. In the plug between the media
Okay.
and
wire.
stent strut. So now is crossbows is going to the back side.
Yeah.
So from this position to
Corsair to go.
Hey, lost
change the
it.
direction,
Okay, sorry.
not
Okay.
easy
Push the wire.
usually.
Push the wire.
And
You
also
can
the
control
system
the
is
wire.
unstable. So if we want to use the crossbows, the backup support is very important.
Yeah, sure.
And so I want to say that this case is an unstable condition, CCS class 3. I don't think there is no associated with the thrombogenic occlusion because this case is a very dominant
Corsair.
direct communication from the distal LAD to the PD branch. But the PD branch itself is, you can see the 90% of the stenosis. That is the cause of the
다른 와이어.
his
다른 와이어
current
달라.
ischemic symptom.
UV3로.
So that if we use a retrograde approach in this kind of the case, so direct communication, the retrograde approach is associated with big ischemia during the retrograde procedure. But for this case, we should care about the PD branch stenosis. Maybe we need the balloon dilatation from the retrograde side.
So wires coming back, I think.
Oh, no.
Maybe. But directing. Maybe.
This is the second track that was
Yeah.
created last time.
Second track.
Yeah.
Okay. I will use the U wire,
Okay.
the parallel wire technique.
You shape
Okay.
over there.
Yeah. I will use a Corsair. In the big coronary artery, even if I'm inside the artery, it looks like outside sometimes. Wire push the wire. Okay. Oh, stop. So, okay. Yep. Pull out. Okay. Do you have any better idea about the selection of the wire here?
In this kind of situation, wire control is very important. So usually we can select the Gaia second or third.
Gaia second, yeah.
But this is already have some space before the stent edge, so that we need to do the more higher penetration power for penetration of
I think so.
the distal end of the CTO.
Right.
So that
So
sometimes we
this
need
is
a
not
conquest or
all,
something.
all total occlusion, and I really like to have tactile feedback from the UV3. So I like to try a little bit more. Then if failed, I'll change to Gaia 2.
So actually, the CTO location is proximal is a stent portion. So what do you think the check of a contralateral injection for the
But we have a very good marker.
Right. So we know, but the CTO location was not in the CTO, stent CTO. So the more proximal portion is
But
CTO.
the contralateral injection does not visualize the proximal to the stent.
I want to see the proximal CTO or proximal stent CTO. So just the proximal RCA location is especially the puncture point or some middle portion.
Oh, yeah, left angio, please. Okay. In this view, you can see just inside the stent.
No. Exceeding the proximal, more
Extending
extended
into the
right.
proximal.
So we can see the some location or some.
Yeah. I'm not sure, but
Yes,
if
but
you
we-
like, if I fail,
But
I will
BK
do
is the
that.
morphology of the proximal side of the CTO is a little bit tricky. So maybe it dissected by the in the past attempt, I guess, so that we can see the some contrast filling in the outside the stents from the today's contralateral injection. So anyway, the difficult point of this case is the distal cap is distal cap of the CTO is very small. So already there's some space around the distal end of the CTO, so that maybe there's some hematoma, something is there. So that's why that we need a little bit higher penetration power of the wire to get the edge of the stents.
what is it? The release of the area.
It's maybe the first track. That means
No, the different from first wire.
that means that
So I can try here. There is some resistance, not far from the right way. I cannot see which one is which. The right side one is U1. Okay, there is a resistance here. So I pushed the crochet a little bit more. Okay, how about that? Yeah, you can see the target outside. Outside. Okay, pull back and try again. Okay, how about that? It looks inside.
Yeah,
Leo?
Leo.
Yeah. The pipeline is much easier to use. Yeah. No,
no.
no. So I need to go outside of this wire, right? Go outside. Maybe I stays in the previous track. 가야 세컨 준비해 주세요. Good thing about this procedure is the strong guiding backup. That's the
Dr.
only one.
Gwon?
Yeah,
Yeah, keep on going. So we are
yeah.
move to the
Yeah.
Seoul
Now
National
it's
University
boring, right?
Hospital. Yeah.
Okay.
Okay, we can come back later.
Yeah, yeah. Thank you.
Dr. Gwon, we are back to
Okay.
you.
Okay. Yeah, we are here. So, previous. I tried the second wire, parallel wire technique with the UV3 again, but it was not successful. It's going nowhere. So, the following Dr. Natsu's recommendation, I changed to the Gaia 2, Gaia second. Gaia second is working differently. I am targeting the outside of first wire at this view. Next. And getting, yeah. Now the inside of a first wire. So wires are just inside at this view. You can see inside the stand. Next. Then still the wire is inside in this view. In two perpendicular view, the wire is inside. So I safely introduced wire. Next. This is Gaia second. Yeah. Second is introduced smoothly. Next. So I exchange it to run through. Next. Next. Yeah. I put the balloon down and pull out. Just that I got the extent of total occlusion. Next. So I used the 2.0 30 millimeter balloon. This is long balloon, 30 millimeter. Next. Next. We did IVUS. Next. 중간에 안 찍었나? 그전 previous. Yeah. No, really?
하고 아이부스.
찍었는데? I'm sorry, I don't have NGO after 2.0 balloon, but actually flow was not so, not TIMI3,
Yeah.
just the TIMI2 flow, suggesting there is some thrombus burden, organized but the thrombus burden there. Can you show the IVUS in the first image? The IVUS on the screen, please. IVUS on the main screen. Okay. This is from the distal stand, the first stand, the Texas. Clear inside. It's a little bit, maybe calcified some in the above the angle, but well expanded here. Coming back to RC angle.
Dr. Gwon, this is done when? After the 2 millimeter balloon or
Yeah,
after
right,
the bigger
right.
one?
Yeah, after 2 millimeter.
After
one.
2 millimeter.
Yeah, 2 millimeter. It's
But
a huge
we
burden.
can't see any so thrombus there.
We
Yeah.
cannot tell the difference between
Yeah.
organized thrombus versus a soft plaque. There was some. Anyway, this is not good, but attenuated soft plaque with some part of the 10 o'clock. There was some thrombus, organized thrombus, I think. I'm sorry, the image is not so great. So angio on the screen, please. The vessel was nearly 6 millimeter, at least more than 5.0. So what we did 3.0,
3.0. Yeah.
30 millimeter. Next. So angio, still. Can you see that? Next. No, previously. Of course, the balloon is inside, but it is not usual way of showing a presentation after the large balloon inflation. So there is some organized thrombus. But next, so I put the 4.0, 40 millimeter Oshiro stand. Next. So we can see here some underexpanded, of course, and underexpansion in the distal to the Oshiro stand. Next. So we did a post-dilation with the 4.0, 15. Next.
4.5.
4.5, sorry. 4.5. NC balloon. Next. Okay. Now you can see some stenosis in the proximal RCA, the outside. So I think it is the tissue protrusion, right? Just suggesting there's some soft plaque. So at this time, actually, patient complains of chest pain. You can see some slow flow in the PDA. You can see that. Of course, there is tight stenosis, but the slow flow was normal before. Now it's slowed. So next. So we did a very long inflation of the balloon. Actually, when I expected some destabilization, the stent itself, I performing a very prolonged, more than 1 minute, nearly 2 minutes of a prolonged inflation of the stent. Then might reduce destabilization, I don't know. But even this post-dilation, we dilated a very long time. Next. Still, there are haziness there, right? Haziness approximately, and also the mid-LC flow was not recovered.
How much was the ACT at that moment?
Yeah, ACT actually, before the procedure, we checked the ACT. It was 250, and we gave 1,000 more. I think it's more than 300. We didn't check afterwards.
Dr. Gwon?
So,
Initially, Dr. Gwon?
yeah.
Initially, you worry about fresh thrombus.
Right. Yeah.
Why do you expect fresh thrombus?
Just 1 month, the duration, and
The chest
large
pain.
vessel.
I think chest pain due to distal region,
I'm not sure.
PDA region.
No, I'm not sure. So, okay, anyway, at this moment, the patient can complain of chest pain more, and the mid-LC and proximal LC, there's some sign of tissue protrusion. Please show us the IVUS.
IVUS on the screen.
Maybe the pain
What's
may be caused by PDA region because the flow is very competition. So
Yeah, flow competition beyond the PDA, but I think it's not because of the lesion, but because of the slow flow. So I can show the angio after ballooning the PDA.
Okay.
Anyway, it's inside of a distal stent, right?
Yes.
This is almost inside of a first stent. Yeah, well expanded, right? More than 4. Let's look at the 10 o'clock. Not yet? Suspicious filling defect, soft tissue in 10 o'clock. Right? You're not sure. So anyway, stent is expanded up to I'm moving the guiding catheter, remove the guiding catheter, and expanded. Next, IVUS. So, right.
Yeah, we have another
I'll
reporting.
let you show the more clearly that I did a negative contrast in the proximal LCA. Can you see that? In 10 o'clock, like a tissue protrusion and some thrombus, some soft tissue. And what do you think? How to deal with tissue protrusion like that?
Well, I usually just pack it for one more time.
Balloon one more time.
Yeah, one more time, and I think that is okay. Especially for
Patient
this
complain of chest pain?
Oh, it doesn't matter.
It doesn't matter,
It doesn't
really.
matter.
Not your patient.
No, he will do fine. He will do fine.
Yeah. So, what do you think? I gave a Nicurandil, intracoronary Nicurandil, and we did a balloon PDA. Next. Okay, so after ballooning, still flow was slow in the PDA due to the balloon.
Yeah, maybe due to the balloon.
Next.
That's the end.
This is then. So maybe I can check the angio again here. Okay. Sure. Yeah, flow was this is after the Nicurandil intracoronary. Flow was recovered.
Dr. Gwon, still we have see the medial part of the previous stent have some haziness there.
Filling defect, right?
Yeah, so can
Do
you
you wanna
apply
balloon
the
again
OCT?
here? OCT.
Yeah,
Really?
Yeah,
because
he
we
had
have a time.
Enough time.
Yeah.
Okay.
Dr.
OCT.
Dr. Gwon, you can either sing or do OCT. What do you prefer to do? Now,
So I like to just live there. Live
you're
there.
absolutely
It's a
right. But
large
what do you
vessel.
say about the distal, the PDA?
Yeah, I just about the stand there. 3.0, 18 millimeter. So I'm a little bit conservative to dilate the distal to the CTO lesion. When the CTO is completely done, that is okay. Actually, why was it crossed here? So I'm not sure. Yeah. Guiding alignment may be a
Yeah.
problem with guiding alignment, right? I used the clockwise rotation and aligned guiding.
Right.
Yeah. Okay. Test. Okay, around here. Test again. Test.
Yeah, should be okay.
Yeah, that's
Okay.
good.
Inflation.
I don't think this is a matter of
12.
conservative. I think you have done all this beautiful job in order to supply
12,
posterolateral
12
and
is okay.
PDA, so you're not going to compromise on a good PDA there.
Yeah. Deflate.
Anybody thinks else in the podium?
Yeah, angio. Should. Yeah, should be okay. Under expansion. Really? Yeah, under expansion proximally. Test. It should be.
Use a short
Is
one.
it wise
Use a
to
short one, yeah. Better to use a short one.
short one?
Yeah.
How about leave it there?
Oh, okay.
18 short. Okay, short balloon. So the
3.29.
Dr. Tsui.
You're going to
recommend-
post-dilate now with an
yeah,
NC
post-dilate
balloon
with the
inside.
NC balloon, right? Yeah.
There is a doggy bone
3
there.
point?
3.0,
어, 오케이.
3.0,
짧은
10 or
3.0.
8.
짧은 거 8mm.
So we have enough time for OCT.
Now,
OCT,
I want to ask the
OCT.
panel, just imagine if there is those haziness in the mid-RCA, if there is, what do you suggest to do? What are you doing in your daily practice?
This
So
patient has
here
a
in my
very huge
case,
RCA
I want to
and,
know
with
the what
massive,
is there.
organ
So the
thrombus, so that
in the IBAS
if
findings,
we-
we are not sure that the what is there in around the middle of the RCA. So if we can see some small protrusion in the we can see the small protrusion in the IBAS findings, we can leave it.
I totally agree with Dr. Nasu, and during procedure, if this protrusion get larger, in such situation we have to some treatment. However, that in this case the heaviness did not change. So if we perform the follow-up angiogram, this heaviness may be clear and
Yeah. It's okay.
beautiful vessel was
Okay,
observed.
inflate.
So no treatment is better
18.
for this case.
Not well expanded.
Higher?
22, 24. Yeah, not higher.
Okay.
Yeah, down. 24 atmosphere. Amazingly, even 18 atmosphere, it was not expanded. Angel, please. Sure. Okay. Still residual stenosis. I don't like to
This
go
is
higher.
good enough.
Yeah.
Yeah, I don't like to go
Go
higher.
on, we are happy.
Yeah, yeah. So you will be happier to have an OCT image, right?
Yes.
You
Okay.
don't want to sing, huh?
but we have 10 minutes, so yeah, we'll try. OCT? I'm not sure OCT is available in 10 minutes. Okay, OCT. So do your panels decide what to do for the tissue protrusion in mid-LC?
I got to
proximal
admit
C?
that in the last injection,
Yeah.
I was not really
Enjoy.
convinced that there is a protrusion there. So, because we
Yeah,
don't
let me
see
check again.
clearly the mid-RCAs out of...
Dr. Gwon, can you
It's
show us
fading
the
out. Yeah, angio again.
audio,
Do you want
please?
angio?
Audio injection, please.
Yeah,
Because the,
injection. Yeah, let me show. Yeah, it got much better,
Yeah.
right? Even mid-LC was much better.
Yeah.
Still, you need the OCT, right?
Can you show us the another view? Audio view, please.
Area view
Yeah.
is going away. Maybe a destabilization, maybe. The stent is
really, it
going in, going
disappeared.
outside. Yeah.
It disappeared.
Sorry.
Is there any ECG change
Yeah.
now?
Now there is no ECG change. Previously, ST elevation about 0.5 millimeter. about 가슴 아프세요? 지금? Yeah,
But
still
we can
complaining of
see
chest
there's
pain.
some distal embolization in the AV
Yeah.
branch.
AV branch.
Yeah.
The
AV
distal
branch
AV
is
branch,
gone?
we can see some embolization.
Ah, right. You can see that.
Yeah.
Yeah. PL branch, right? PL branch. There.
Yeah, in the distal
okay.
part.
It's embolization.
Right.
So, do you want to retrieve it?
Yeah.
If you like, come over and retrieve it. OCT? So I prepared for the old aspiration catheter to get out the thrombus out of it. And what do you think about the intracoronary thrombolysis and the big burden of a thrombus? Still somebody is utilizing that intracoronary thrombolysis?
Well, I use it in the refractory case.
Oh, refractory
Yeah,
case.
refractory to aspiration, refractory to angiogram. And
Okay.
I will give,
You have angiogram.
yeah, I have angiogram.
That's much better solution, right?
Yeah.
Still, you use thrombolysis.
Well, if it is refractory to all those and still cannot achieve a TIMI free flow, then I will use
Some thrombus
a-
is
a-
refractory to angiogram.
Yeah,
Wow.
that's right. So I just give 10 milligram of TNK.
Yeah.
So there's two branches with embolization. Would anybody give a 2B3A inhibitor instead of thrombolytics? There's two cutoff branches there.
I don't think 2B3 is working in this situation. It's fibrin thrombus. The 2B3 is antiplatelet.
And for this small branch, I prefer to avoid the risk.
Yeah, right. Leo? OCT 연결됐나요, 근데? 이 정도까지 해야겠다. 오케이. OCT 바꿔주세요.
Can we see in the bigger screen the O?
Yeah. Okay. So, yeah, ready? Shoot. Okay. Let's pull out. Oh, yeah. It's the 12 o'clock. Where was it? It can be co-registered. Co-registration? Yeah.
That's
it's
very nice.
co-registering. Yeah. 거기까지 왔나? 그거보다 위에 아니야? 맞아? 찍는 게 마커 여기 있는데. 아닌가? Okay. Okay, yeah. So, where is the thrombus? Okay, The proximal, proximal. Okay, here. Middle C, yeah.
Yeah,
The
you could see it.
proximal, yeah, 12 o'clock. Yeah, 12 o'clock. Yeah, the previous one.
Yeah.
A little bit distal. Proximal. That's clear. So, yeah, it's clearly can see the tissue protrusion. But
That is the
you cannot.
haziness in the mid, I would say. Yeah.
The thrombus 다시 좀 보여주세요. So in OCT image, thrombus 12시 방향에 있는 거. Stop. Yeah. There's some attenuation of light
Right.
there, so there's a red thrombus.
red
But
thrombus.
I don't think we can tell the difference between thrombus and tissue, and I don't think there is differential treatment. The treatment is different for those lesions. Do you want to dilate it further?
No.
No. Thank you very much.
So anyways,
really appreciate
from the recent OCT data, so definitely intrastent thrombi or intrastent material has no further effect on the clinical follow. However, anyway, the most determining factor is the size of the intrastent thrombi. Yeah, so
lumen
anyways, you already checked the OCT, so it's better to measure the maximal cross-sectional area or of this intrastent thrombi.
So in point of OCT, you think this is a not large tissue protrusion? Dr. Kim?
Yep.
Yeah, do you think this protrusion is not so large in OCT?
Oh yeah.
right?
So anyway, this is the live demonstration. So
Yeah.
the size is 200 micrometer.
200.
Yeah. So we want to see the size of this
200
case.
micrometers is 0.2 millimeter. Larger than that. Anyway, I like to leave it here. Okay, so
In the case is what's your plan for the further medical drugs?
medical treatment.
Yeah, medical
So
treatment.
as usual, I think. Do you think ticagrelor is needed for this patient?
Well, personally, I will.
You will.
Yeah.
Oh. How about Dr. Song?
Yeah, I prefer.
You prefer ticagrelor. Okay, yeah, ticagrelor, why not? It's a young patient, not HBL patient, not so young, the higher than 60, but not younger than 75 or 70, so why not? Okay, so I'd like to have a final angiography.
Yes.
Hopefully
Please.
better. Should? Distal. Yeah. 알아요?
Dr. Gwon can show us. Okay.
Okay, another view. Distal 봐야 돼요. Sure. Okay, distally. Yeah, very distally. And RC is giving
I
the
think we
collateral
are happy,
dilating.
Dr. Gwon, and we shall call it a day.
Yeah.
Don't you think
Thank you very
so?
much.
All right, thank you very much for a fascinating case.
Thank you, Dr. Gwon.
Do you have any final comment? No?
And, it's
Okay,
good, very
thank
good,
you.
very
Yeah, we are happy.
Thank you.
Yeah.
Thank you very
Okay.
much. Thank you.
우리도 하자.
Thank you.